Thank you, Stu, for the introduction, and thank you all for the invitation to speak here. This is a very broad topic, perioperative pain management of opioid-tolerant patients, and something that I will make no pretense of being able to cover in any degree of depth in 20 minutes. But what I'd like to do is just have a thoughtful discussion and where we are in terms of direction. Opioid-tolerant patients, what is the burning platform with that? How many here have taken care of, from an anesthetic perspective, opioid-tolerant patients? What is the top emotion, and I use the term emotion, but what is the top feeling that comes when in dealing with this, do you think? Or what word comes to your mind when you think of these patients? Frustration. I'm sorry, neediness. Okay. Very true. I mean, one of the most challenging group of patients to treat in the hospital, if you were to walk around on the floors, not just in the operating room, they are easily identified on most floors as the patients that most providers find challenging to treat. It's not just challenging from a medical sense, but they can very often provoke emotions in us as well as we deal with these patients. We'd like to influence their outcomes, however. We'd like to improve how they do, and those have some unique considerations I'd like to talk about. We think of it in terms of analgesic optimization. When we think of these patients, they're opioid tolerant, as we just had an excellent talk about the fact that increasing doses of these medications sometimes don't have enough of an effect. How do you optimize? But it's more than just analgesic optimization in these patients that has to be looked at. And what is the best way to do that? What are the evolving healthcare delivery models in the care of these patients who very much take up a lot of time and space? So what is the burning platform? Well, is there data to support what we feel, that these patients are challenging, that their outcomes are not quite where they should be? As Stu pointed out, I've now had the benefit of working in 3 different health systems, and I can assure you that the data I'm sharing with you from Duke is mirrored in the other 2 institutions as well. So I've pretty much covered the East, the West Coast, and now a little bit of the South here. So the data, as you can see over here, is basically 1 in 12 patients admitted are opioid tolerant at the time of admission. So that's pretty impressive. 1 in 12 patients come in on high doses of opioids. And what do we define as high dose of opioids? We use the FDA definition that they have to be on 60 milligrams of oral morphine equivalents for at least 7 days. These are 3 hospitals that are within the Duke Health System. This is a 900-bed hospital, a 400-bed hospital, and a 200-bed hospital. As you can see, the data is pretty much similar in the number of these opioid-tolerant patients that come. We then wanted to look at outcomes of interest, the ones that we judge our care by and we are judged by, is length of stay. So how do these patients do? And what you're seeing here is the orange bar is the opioid-tolerant patients compared to control, which is not necessarily patients on no opioids, just less than 60, anywhere from 0 to 60. As you can see, as far as length of stay is concerned, there's really no statistical difference. These patients do just fine. And a lot of that has to do with the fact that there are immense length of stay initiatives to get patients out of the hospital in time. What that does, though, however, as you can see over here, is 30-day readmissions. So do they come back within 30 days of an acute care hospitalization? And here's where you start to see the opioid-tolerant group race away and take the lead over here. As you can see, a pretty high readmission rate. We can get them out, but they come back. Same thing with the emergency room. Within 30 days, they have many more emergency room visits than do patients who are not on opioids at the time of admission. The med harm rate, lower is better. And as you can see, even here, these patients don't do as well. They have more adverse events when they are in-house. Patient satisfaction. We just heard the word needy, okay? Single-handedly, this population across the board, and as I said, now in 3 different health systems, 15 to 20 points lower satisfaction than patients who are not on opioids at the time of admission. So undoubtedly, this is a group with poor outcomes, to say the least. But while we're talking about outcomes, there's one other thing we need to discuss, and that is, the third wheel that we don't talk about. We talk about analgesic optimization, improving, the usual outcomes in this population. But one of the other things we're dealing with, the opioid epidemic, which is the topic of this, this session. How do you influence that? Do we have a role to play in that? Because for the most part, as you just heard me in the previous slide, our approach is these patients come to us. Some unknown entity in the outpatient arena, in the outpatient world, seems to create these people, and they are opioid tolerant, from their chronic pain conditions. They come in, And we're just receiving them, and we're taking care of them as best as we can, with the cards we've been dealt, and then we try to send them out in the best shape possible. However, there are some that disagree and feel that hospitalizations, and especially surgical episodes, in many ways start and then escalate the opioid tolerance in this population. And it has to do with the fact that we do send them out on significant doses of opioids. So what we did here, and here this is again at Duke Health that we looked at it. What we did is we looked at all the major DRGs, or diagnosis-related groups, in the inpatient setting, and we basically classified patients as naive, which would be less than 60, or tolerant, greater than 60. And what this is showing you is blue is they came in naive, and they left naive, which is after whatever they had done in the hospital, they left on doses less than 60. Naive that went to tolerant, orange. Now this is the area of concern. This is the one you want to look at to see why did they come in on very little opioid and leave on a significant amount, or zero opioid and leave on significant. And then of course you have the tolerant patients. Our belief is that it's this tolerant patients to tolerant that is the major issue, but what you're going to see over here is in 3 major DRGs, major joint replacement, surprisingly cesarean sections, and in spinal fusions, you have a lot of orange, which would indicate that our protocols, or the way we manage these patients, we send them out. Patients who did not come out on significant amount of these medications come in on that. We send them out, though, on a significant amount of medication. Now, you may well say joints can be painful surgery. Spinal fusion is definitely a painful surgery. Cesarean section, depending on how you look at it, could be painful, certainly. The challenge is, what are we giving them, and is it the most appropriate way to manage these patients? One of the concerns that comes up is, it's fine that we're giving this to them, but we expect them to wean off. We expect them to come off of these medications pretty much, within a few weeks. But we all have this, suspicion that not everybody comes off of these medications once started. And so what you're seeing over here, and it's a little bit of a busy slide, but I'll just walk you through it. For major joint replacements, for instance, these patients, on average, there were about 600, left on an oral morphine equivalence of 150 milligrams, okay, on average that they were sent home on. And at 2 weeks, the majority of them dropped down to 60. They were only using 60. So that's a pretty steep drop, and a question of whether they'd really needed that much to begin with, if within 2 weeks they were able to drop down to that. And then you do see that sustained, about 66 patients who continued on opioids. Now, this is a little bit tip of the iceberg. Please, you have to recognize Duke especially is a regional center, gets patients from the 5 neighboring states. So a lot of these patients, the year-long follow-up, we may not get back, and this data only looks at those patients that came back into Duke. But even within Duke, you can see that we are not getting these patients off these medications, even a year out, necessarily, at least not all of them. Same thing followed with cesarean section, except a smaller number here. 2 patients seem to have just gone to a whole other level, which was not completely explainable. And then you have the spinal fusions, which again, they leave at a certain dose. They actually, in 1 to 2 weeks, seem to need a little bit more, and then they drop down significantly but stay on these medications. Another way to look at it is, does everyone need the amount of medication that we're sending? So yes, the effect on the patient itself and their chronicity and their, they become chronic use patients. But also, is there excess being sent out in these episodes that is leading to the prescription drug abuse epidemic? Because as you'll know with most heroin users, they'll say they started with prescription drugs, and they started with their friends and neighbors or their parents, which is really what has caused most of the angst and most of the concern, is that there are an untold amount of non-medical use of these prescription opioids, not medications that was sold on the street. These were medications that came out of healthcare settings, okay? And so what we did, and this is paper, is on its way out, but a little slower than Dartmouth, which is already published on this, and shown that post-operatively, what they did is they took various surgeries and they followed these patients to see how much do you actually use. What they found is, for the most part, everyone gets standard prescriptions. It's a default prescription of 30, 45, 60, you name it, whatever the computerized order entry default is, they get to go out. And how did they come up with that amount? No one's quite clear, except probably they were trying to treat the tail and make sure they got the least amount of calls back, for medications. And so, but however, one size fits all, everyone started getting a large number of medications. And in their study, what they found is patients used about 28 to 30% of their prescription. the majority of on average, which means 70% excess medication with every episode post-hospital that they were going out with. We did the same thing over here. We did a study with the urology population where we have the same data right now for cesarean sections, for neurosurgery, for orthopedic surgery, thoracic surgery. And similar findings, which is, here there's 100 patients, thereabouts, 61 of them responded. On average, they used 30% of their prescription. So we were definitely sending out way more than they needed. And what what else was happening was, well, we wanted to know what they did with the excess medication. First, they did not recall education on disposal or what to do with these medications at all. So most of them retained it. As you can see here, 32 of them out of these 43 retained it. 6 of them flushed it down the toilet because there's some ambiguity on what you should do with it. 3 of them threw it in the trash. 1 took it to the take-back program in the police, a really diligent individual, really, and 1 guy just decided to bury it in his backyard. And I'm totally not clear on what that purpose was. But here, what's that? I'm just worried about who's going to take that, and if he has a vegetable garden close to it. Exactly. So, and the IRB would not let me ask him anything more, otherwise I really did want to find out why he did that. So what we did with this is important information. As you can see over here, in the proportion of patients using this excess, there's a long tail. There are some patients who use the entire prescription, but actually of the 11 patients who use the entire prescription, a majority of them did it because they didn't understand PRN. They didn't understand as needed. One of them thought he had to complete a 10-day course, so he actually came back after his 7-day prescription to get 3 more days because he thought they hadn't given him enough. Not for pain, he needed to complete the 10-day prescription. So there's some misunderstanding and there's some patient education issues there, to say the least. And some of them were chronic pain patients who were using it not for the purpose prescribed, but to add to help with their chronic pain as opposed to their post-operative pain. So we have actually initiated a system where now for laparoscopic procedures, they leave with 11, not 10, not 15, we didn't round it off. We said 11. And we did that so people could start to recognize that we don't need to round this off. We don't need to send it out. It's okay to say this is what 75% of patients will be perfectly fine with 11 pills. That is what we're going to send them out with, just to change our culture. For the open procedures, they are more painful, and they were 20 pills. So this is where we end. And this is the direction we're taking, which is more customized discharge prescriptions. What we're hoping to do is also look at factors that may predict patients who might need more or a different dose, so we can be more specific in our prescriptions as they go out. We talked just a few minutes ago about more than analgesic optimization. Well, how do you approach these patients? Obviously, we do contribute. We have a responsibility to manage these patients. What are our goals of care? Well, ideally, we want them to be optimally pain managed, and because at the same time, not having them managed for pain does not improve outcomes either. Definitely not perioperative outcomes. Patients don't do well, we know that. So we want to get their pain under control, but does it have to be opioids and opioid escalation is the big question. We want them mobilized early, because they do well with that, reduce their length of hospital stay, and have them satisfied at the same time. And this is the one that gives the conundrum to everyone, because the thought is if you don't give them their opioids, they're going to be very unhappy with you. But just as Dr. Mao just explained, with the increasing doses of opioids and no change in the pain scores, even for patient satisfaction, there are multiple studies out there, including from emergency rooms, which show that patient satisfaction is in no way linked to the opioid dose prescribed. What they were most responsive to was staff responsiveness. That seemed to have a correlation, but the actual dose of the opioid had no correlation to the satisfaction that patients expressed with their care. So how do you optimize? Now, what I haven't included here is readmission and 30-day ED visits. As you know, the Center for Medicaid Services has quickly recognized that the cost of care is not that episode, but the continued episodes, them coming back in. And so there's a real focus to try to minimize those moving forward. So what is the preoperative optimization that we can do, and we do currently? You notice I put up here psychological optimization first. And we really do need to screen patients for fear avoidance, catastrophizing, and any mental health issues that they have, because if those are not addressed, then the opioids, as you know, Dr. Mao just educated us, they do good for anxiety. They have some effect on it. Do they improve outcomes with it? Is that your first choice of agent for anxiety? Probably not, right? And so could we be more appropriate in what we're giving them if anxiety, depression, catastrophizing behaviors, et cetera, are the main reason? For instance, there was a paper on catastrophizing where, they used SSRIs and found improvement, preoperatively in their outcomes. Consider cognitive behavioral therapy, relaxation response, giving them the skills before they go into surgery, and then continuing them ongoing. From a medical optimization standpoint, when we get these patients preoperatively, we actually work to wean these patients off their opioids and use other modalities for pain control. And in the next slide, I'll talk about how we do that or why we do that and what the data says about it. We enhance the multimodal approach. We really emphasize to them the importance, even if they tell me that, we've tried all these multimodal medications, they've never worked for me, I don't really want to try them. We talk to them about preparing for surgery, preparing for a stressful episode, and how important it is to come down off of the medications that are most likely to, impact their outcomes. Could be opioid-induced, respiratory depression. It could be wound healing. There's data to show that it impacts that. Increased infection rates in these populations. And we share that information with patients. Seems to motivate them. They understand this is a stretch that they have to prepare for, and they are much more motivated to start to work on that a little bit more. Physical optimization, prehabilitation, we get them to improve their exercise tolerance. This isn't somebody who needs to get on a treadmill. We just start to get them engaged and activated, because the CPET studies show you that even a small increase in activity before surgery improves their outcomes afterwards. Nutrition, we do talk about nutrition. As a pain physician, I really had not thought I would spend as much time as I do, but we actually go over nutrition with them, what they can do, what they can't do, what they should be focusing on to try to improve their wellness overall and prepare again for this surgery. In conclusion, for this strategy, the optimal strategy that we employ is reduce opioids, improve, enhance other medications as far as possible to try to improve the care of these patients. And we base it off of, increasing evidence. I'm not by any means suggesting that it is, foolproof standard of care yet, but there's increasing evidence of the benefit of both preoperative opioid weans and psychological screens. So you've got multiple papers that show you, that if patients had successfully decreased their opioid consumption before surgery, substantially improved clinical outcomes across the board. They did way better. And it's interesting that way better was comparing them to patients who didn't use opioids at all, just trying to get their outcomes to be the same, okay? In this particular one, increased preoperative opioid consumption, the somatic perception questionnaire, and the depression scale prior to spine surgery predicted worse patient outcomes. And and there are options, as we've just discussed, to try to help these patients before their surgery so that they can actually do better, as they recover. Same thing over here again, and it's in abdominal surgery, in the knee arthroplasty patients. The data now is across multiple surgical procedures that an approach along these lines actually improves clinical outcomes. The 20 minutes don't allow me to get into every drug and every modality that we could use to do this, but you're going to get an excellent range of those topics discussed today. I just wanted to briefly look over the strategies that we do use. From an preoperative standpoint, we do optimize the non-opioid medications that we have options for. And intraoperatively, we do recommend, where you can, use neuraxial and regional techniques. Where you can, the use of IV lidocaine infusions. Ketamine infusions has shown improved data. That said, I'll put a little asterisk here, and for those of you, I'm in an August audience here, people researching this right now. The ketamine and lidocaine we've started to look at in the clinical arena, that there is a slight uptick in adverse events currently occurring with these infusions, which we really had seen as a savior in these opioid tolerant patients. However, there have been a lot of unplanned visits back into the ICU, and we're trying to investigate that further to understand why. The ratio is about 1 in 5 patients on these infusions seem to be going back, in spite of having protocols in place to ensure that there are exclusion criteria for patients at risk with these. That said, I apologize, let me get that. So what are the various healthcare delivery models? How can we take care of these patients? Traditionally, we have pre-admission testing clinics that optimize these patients. Truly, it's more screening than optimization in that. There are referrals, et cetera, made. There are many of these patients that you would think are part of chronic pain clinics, pain management clinics already, and probably is that the source for them to get it? Should it be the surgical clinics? It was really, really very hard to find the right place for these patients to get the comprehensive care they likely need to optimize them before surgery and to provide ongoing follow-up after surgery, because unfortunately just preoperative optimization may not be enough. So towards that end, at Duke, we started in March of this year the first perioperative pain clinic. It's purely dedicated to these patients, and it's not, you don't have to be on chronic opioids, just as an alert there. Surgeries that are known to cause acute to chronic persistent pain states, we accept those patients as well early and optimize them and continue follow-up. So what we do is we get them anywhere from decision to surgery. And when I first started this clinic, our thought had been, 1 to 3 months is when you usually have decision to surgery before the patient goes. We use this time for early intervention and optimization. Interestingly, many of our surgeons at this point don't even give them a surgical date. They just send them to us and ask us to let them know when we think that they are optimally ready. Our clinic has pain physicians, psychologists, physical therapists, so hitting all of that, nutrition consultants. And all of these people work with these patients to try to get them to the best possible shape. But also, this is the team that will follow them inpatient and get them on the outside. And we follow them for up to 90 days post-discharge, so that the care is continuous and they're getting a chance at that. We work with their chronic pain physicians. It's not that we take over care without their permission. In fact, there are some chronic pain physicians, and given our geography sometimes for the patients, it's better. They will manage them, but they will do so with the ability to have MD to MD access for any questions or concerns that they have. This clinic has done reasonably well for us overall. Again, as I said, it's just started in March. The data that I'm showing you is still early. At this point, we've had over 400 patients go through the clinic and complete the 90 days. That data is being propensity matched at this point to show outcomes. I couldn't share it with you at this meeting. But the early interim analysis does show that this early pattern that we've seen is persisting, and that there is some benefit to this. As you can see, our geography over here, this is North Carolina, Duke somewhere over there. Our patients come from very far away. A travel time of 4.5 to 6 hours is not uncommon at all for these patients. So one of the challenges a clinic like this had is, for a patient to come regularly for the optimization. Is that even possible for them? The majority of patients come from ortho, from spine, thoracic. Our transplant services have found Duke's a large transplant center, and both our lung transplant and solid organ transplant services send these patients to us very early, actually. So when my 1 to 3 months is gone, we pretty much we get them, and then it's whenever they get their organ, and we do follow them through that period. Okay. All right. And so the outcome over here, as you can see, is this is early. In the beginning, they used to be sent to us 10 days prior to surgery, which doesn't give us much time, but nonetheless, we were able to do about a 10% reduction in their opioids. And I wasn't able to finish this graph, but I can show you that, I can share with you that they did way better even post-operatively compared to patients who were not sent to the clinic or who did not have that. So a real reduction in opioid doses. Currently, we're trending more average of 30 days before that the patients are coming to us, and the opioid reduction is closer to our target, which is about 50%, which is what the papers so far show gives benefit. What we see over here in expected versus observed length of stay, and expected length of stay is a risk-adjusted number, so we can really compare to that. Patients who come to us preoperatively, we can keep them at their expected lengths of stay for the most part. And in fact, in thoracic surgery, we were actually able to improve on that as well. This we compared to a group of patients who were sent to us after surgery, not sent to us for preoperative optimization, and you can see where their lengths of stay were when compared to expected. And so we do believe that this is at least showing early trends of improvement. With that, I'll stop in the interest of time, and thank you very much.